I'm Peter Block with the CardioSource Heart Minute, and today I'm together with Dr. Chris Cannon from the Brigham and Women's Hospital. We're talking about some of the interesting stories that have hit the journals over the last couple of weeks. And one of the things in circulation, one of the reports in circulation, is a Danish registry report on ST segment elevation myocardial infarction. And the problem that candidly I deal with every day as an interventional cardiologist, which is what to do with a patient in atrial fibrillation who comes in with a STEMI and needs a stent. Question is, should you give them single therapy, double therapy, what kind of double therapy, or triple therapy where the bleeding risk obviously goes up? So Chris, your take on this registry report.
Well, out of this, I think this problem is the more antithrombotics we add, the higher the risk of bleeding. On the other hand, with a stent and coronary disease needing dual antiplatelet therapy and warfarin needed for the atrial fibrillation stroke prevention, we really do need triple therapy. Shortening the duration and tightening the management of the anticoagulation has been what the guidelines have recommended. So trying to use bare metal stenting and then shortening up the duration of dual antiplatelet therapy, and then ending up after a period of 1 or 3 months with aspirin and warfarin, hopefully titrated to an INR of 2 to 2.5.
You know, these are such difficult patients, aren't they? And I never win on this one, right? It always depends on whether the last patient bled or had a thrombotic event. And so I think what we need to do is have better trials. I'm not really very impressed by this. What we learn is what we already knew. The more antiplatelet agents you give, plus an anticoagulant, you're going to end up with more bleeding. Is there any place here for the new agents?
Well, many of us are hoping for that, and there is a caution from the American Stroke Association saying that we really don't know the safety of the new agents with antiplatelet therapy. There's been a report of single antiplatelet therapy and the new agent dabigatran that looks pretty good, I think also with apixaban, but dual antiplatelet, I think there are trials being discussed, because an advantage of those agents is less bleeding, depending on the dose and agent. So it remains a potential for the future, but currently we just have titrated warfarin to a low INR.
Thanks, Chris.